today's episode of Myeloma Crowd Radio, a show that connects patients with myeloma researchers. I'm your host, Jenny Alstrom. We hope you're having a great summer, and we are enjoying ours, and we'll be looking forward to a busy fall with more Myeloma Crowd roundtables. Now, you listen to this program because you want answers from myeloma experts, and the roundtables are live meetings where you can listen to live myeloma experts in person. The roundtables cover new treatment options and hot topics like immunotherapy, but also focus on relapsed and high-risk disease because these patients need help the very most. We will be announcing our next roundtable meetings shortly. Now, what we've heard from the major conferences covering myeloma is that even with all the new therapies, stem cell transplants are still key in myeloma treatments. Drugs or other treatments are now being added on the front and back end to make transplant even more effective. So joining us today is Dr. Philip McCarthy, who is a stem cell transplant expert, and he joins us to share his findings from recent research just completed at the Roswell Park Cancer Institute. Welcome, Dr. McCarthy.
Thank you, Ms. Alstrom, and I apologize for being late.
Oh, no, you're totally fine. Perfect timing. Let me give an intro for you before we get started with our questions. Dr. McCarthy is director of the Blood and Marrow Transplant Program at the Roswell Park Cancer Institute. He's associate professor of medicine, a member of the graduate faculty, and a professor of oncology and internal medicine. Dr. McCarthy is a committee member for local, regional, and national groups, including the core member and associate chair of the Multiple Myeloma Committee, core member of the Transplant Committee, Cancer and Leukemia Group B, which is called CALGB, now called the Action Alliance for Clinical Trials in Oncology, a FACT or FACT Clinical Standards Committee member on the Blood and Marrow Transplant Clinical Trials Network for Myeloma, an ASH scholar in the Clinical Study Section, a member of the NCI Myeloma Steering Committee, and the Myeloma and Lymphoma CIBMTR Working Committees. So extremely involved in kind of creating the direction for myeloma transplant. Dr. McCarthy has been a clinical investigator in oncology, particularly in bone marrow transplantation, for more than 20 years, and his research interests are devoted to helping new auto and allo treatments for hematological disorders or blood cancers, including myeloma, that will lead to improved patient outcomes and decrease toxicity. So, Dr. McCarthy, thank you again for joining us.
Oh, thank you for the kind invitation. It's always great to speak with patients about all the new ways we can treat this disease and hopefully someday cure it.
Oh, I agree. So let's talk about transplant because as a little intro, I know in the news recently was something we're going to be discussing, which is one of the papers that you presented at the recent ASCO conference. But maybe you want to step back for a minute and give us an idea of the role of transplant in the aid of new therapies. I know patients all the time think, well, if we have these new drugs, will stem cell transplant eventually go away? And at ASH this last December, we heard about lots of new therapies, but we also heard a key message that transplant was still a core and valuable treatment.
Yes, there were actually two recent studies. One was the French-American study. Michel et al. From the French group presented data looking at an upfront treatment of transplant versus transplant at first progression after primary therapy. And all the patients in the French group and in the United States received similar upfront therapy. There's a difference in maintenance, which I can talk about in a sec. So he presented the French portion of the study, and they had about 900 patients who received either lenalidomide, bortezomib, dexamethasone. Everybody got that, but then followed by either transplant or collect stem cells and then transplant at progression. So it was 3 cycles of so-called RVD, len, bortezomib, dex, and then stem cell mobilization with cyclophosphamide, which we don't always do in the States nowadays, but it was done to make the study more homogeneous. And then again, for the patients who were assigned to high-dose therapy, they received melphalan, stem cell rescue, and then a same RVD consolidation, and then followed by len maintenance. For the other arm, it was 8 cycles of RVD and then len maintenance. And in France, they did only a year's worth of len maintenance, there's a whole discussion about second cancers. We could talk about that in a sec. But what they showed in this study was that the patients who received the upfront transplant had a superior progression-free survival. And I think that was one of the questions you had posed, what the difference is. What that means is that it took longer for the disease to come back if you received a stem cell transplant, whereas if you got RVD or chemotherapy alone, the disease came back sooner. And there was a significant difference. However, when you looked at the overall survival, it was essentially the same. There was no difference between the two arms. So that meant that the patients who had progression of disease were still alive and were likely to receive salvage therapy and then potentially go on to transplant. They didn't present that data, but they did show that the 3-year survival was over 80% for both arms, which is really had been unheard of. This is really an advance. Now, you want the 3-year survival to be 100%. We're not there yet. But this showed that transplant was still a valuable option in terms of preventing the disease from coming back sooner relative to, say, receiving chemotherapy. And do you want me to talk about the ASCO trial? The ASCO presentation from the Europeans?
Sure.
That's EMN02. That is a European myeloma network trial. And what they did, that was presented by McCarthy on behalf of the European Myeloma Network. And they had a little different one. They started with a bortezomib cyclophosphamide dex. They call it VCD. In the States, it's sometimes called Cybor-D, cyclophosphamide bortezomib dex. And there's different flavors of how it's administered, the different dosing and things like that. But they had a fairly standard dosing schedule. And patients got 3 to 4 cycles of VCD and then high-dose cyclophosphamide to mobilize stem cells. And then they were assigned or randomized to either bortezomib, melphalan, and prednisone for 4 cycles in low dose, or they got high-dose melphalan for 1 or 2 transplants. If there wasn't a good enough response, they got 2 transplants. And then there was a further randomization to a consolidation with bortezomib blendex, VRD or RVD, as you want to say. And then that's for 2 cycles versus no consolidation. Then all patients got lenalidomide maintenance at a schedule of until progression at a schedule of 21 days on, 7 days off, so 21 out of 28 days every 4 weeks. And that study showed that there was a significant benefit to the transplant arm in that patients who got a transplant had a superior progression-free survival again. There was about an 8-month difference at 3 years in terms of progression-free survival, so that the transplant arm, it took longer for the cancer to come back. And again, there was no difference in overall survival. But again, it's in both this study and in the French-American study, they're early, and just because now that we've gotten much better therapies, people are fortunately living longer, so it's going to take longer to see if there really will be an overall survival difference between the 2 different treatment modalities. Plus, because people can get salvaged with newer drugs, because there are lots of new drugs, it's harder to see an overall survival difference, because it's not like if you progress after chemotherapy, there's nothing you can do. There's actually many things that can be done. And then one last thing, the French and American study, the Americans, led by Paul Richardson, are doing a little bit different maintenance strategy in that patients, instead of getting maintenance only for a year, it's maintenance until progression. And so we think that is probably better, and that leads into the study that I was involved with that was presented at this year's ASCO. And we also represented it, a similar one at EHA, the European Hematology Association. That was right afterwards, a couple weeks later. And what we were able to show there is we took the 3 studies. We took the French study that was published in 2012, IFM 0502. the New England Journal of Medicine study, which is New England Journal of Medicine paper that we presented, the CLGB 100-104. Sorry about that. And the Myeloma trial, which is the Italian study. The three studies all looked at lenalidomide maintenance until progression, and versus either a placebo or no therapy. And each study showed a progression-free survival benefit. In other words, those patients who received lenalidomide it took longer for the disease to come back. The French study did not show a clear overall survival benefit, and the Italian study, same, they had a trend. Whereas in the U.S. study, the 100-104 study, we did see a survival difference. So, what this meta-analysis did was look at all three studies. So we pooled the data from all three, the French, American, and the Italian studies. So now we have over 1,200 patients, 605 who received len maintenance, 604 who were control patients, either placebo or no treatment. And what we were able to show, the bottom line was that the control arm, those who did not get maintenance, had a median overall survival of 86 months. So that meant that at 86 months, half of the patients had died of their myeloma, but the other half were still alive. And if we looked at those who got lenalidomide, the median overall survival has not yet been reached. We could do an estimate that it's probably going to be close to 116 months, and the hazard ratio between them showed that it was 0.74. So what that means is there is a 26% reduction in the risk of death in those patients who got lenalidomide, and this translates roughly to about a 2.5-year increase in median survival. So obviously we want to make it so that everybody is alive for a prolonged period of time, but this we think is a big step forward. When we look at 7 years after from the start of the study, the 7-year overall survival is 62% for the myeloma for the lenalidomide patients and 50% for those who got placebo or control. So this to us means that the lenalidomide maintenance can be considered a standard of care. In all of these studies, it was until progression. There's a lot of controversy. Some people are saying, well, do you need it for only 2 years, 3 years, 5 years? We don't know that answer yet, but we at least know that lenalidomide maintenance does prolong survival when you looked at the three studies together.
Mm-hmm. And what you said was dramatic, so I just kind of want to call it out, because the original studies were just looking at how long did it take to progress or progression-free survival, and then your analysis that was just announced was looking at just the overall survival. So you said you saw a 26% reduction, and then
in the risk of death, yes.
Right, and a 2.5 increase in overall survival by using lenalidomide maintenance until the disease progresses again. So that's very significant.
Yes, we're pretty excited about this because, as you pointed out, all three studies were PFS studies. In other words, they were designed to show a difference in progression-free survival. And a secondary endpoint on all three studies was overall survival. So they weren't really powered. In other words, to do some of these studies, you have to have several hundred patients to be able to see a difference, especially in overall survival. For PFS, you need smaller numbers, but even then, the CLGB 100-104 study was like a 460-patient study with half going to len maintenance and the other half placebo. And the French study was over 500 patients. The Myeloma study was about, I believe that was around 250. So either way, you have to have a large number of patients for just progression-free survival differences. And now we're seeing that because we have better therapy than we did, say, 10 years ago, we now need to have larger number of patients to see if there's going to be an overall survival benefit. And as you can see, it took many years to see the difference. So now what we're trying to do is develop are there earlier endpoints that we can use to help us predict long-term outcomes? So this whole concept of minimal residual disease by flow cytometry or next-generation sequencing, if you can go into what we call MRD negative state, in other words, there is no minimal residual disease, is that appears to predict for better progression-free survival and probably overall survival, but still people who are MRD negative have progression of disease. So there are other factors that are involved that are with long-term control of disease, and we just need to understand those more.
Mm-hmm. And one question is, when you have these hundreds of patients, because that's a lot of patients and a lot of data to look at, can you go retrospectively and say, okay, and when it comes to maintenance, is there a difference in a particular type of genetic feature of the myeloma, or for whom did this work the very best, and for whom did it not work? Yeah,
that's a good question. On 100-104, we did not have very good cytogenetic data because when the study opened, unlike the French, who have been a little bit ahead of us on this, a lot of places did not do what is called CD138 selection of the marrow to pull out all the plasma cells. Plasma cells expressed CD138. So you pull out all the plasma cells, and most of them are malignant at diagnosis. And then you can, the laboratory can look to see what kind of chromosome abnormalities are associated with the myeloma, and that helps with prognosis because there's certain chromosome abnormalities that are poor risk, and then some that are better risk. Mm-hmm. And so on the French study, they have not completely, we've only, they had an ASH abstract a few years ago, but they have not actually officially published it. They mentioned in the paper that they saw benefit even in high-risk cytogenetics. When they actually had in their ASH abstract, it said that deletion 17, which is a poor risk abnormality, benefited from Len maintenance. But again, that's only in abstract form. It was controversy about 414, which is another one. So at least right now, it appears that some will benefit. When we looked at subgroup analysis, we still see, though, that adverse cytogenetic risk is not completely overcome by Len maintenance. This is called a subgroup analysis. And that showed that it was probably not as beneficial as somebody who had better risk cytogenetics. So it points out the fact that we have to do better in this patient population. So, for example, like in the HOVON 65 trial, where they looked at 2 years of bortezomib maintenance, deletion 17 also benefited, but again, 414 did not. So there's been some phase 2 studies, sort of non-comparative studies, that have shown that you can retrospectively look back and go, oh, RVD or Len bortezomib dex in a lower dose, the Emory group published this, for a prolonged period of time controls disease for an extended period of time, but they didn't have a comparator. So we need to start looking at newer modalities and newer treatments for controlling disease long term, and thus we're very excited at some of the newer drugs. So, for example, like daratumumab, the antibody, there are studies now that are examining it as part of maintenance therapy long term. We're very excited because we do know that this type of antibody seems to work against even high-risk cytogenetics, and will this be part of how we can control the disease long-term, even in bad-risk cytogenetics?
Mm-hmm. And going back to what you first started out with when you were talking about the different studies, the transplant studies, if they had better progression-free survival, if someone does a transplant up front or early in the course of their disease, would one of the strategies be to do that because regardless of the overall survival, because so many new things are coming out? And you can say, well, gosh, if I kick my myeloma out 3 years, or whatever, it's likely that I'll have lots more options than if I try to kind of take it easy and not do the transplant up front. Or what, as a transplant specialist, what do you suggest? Because you see many, many patients.
Sure.
And you have deep expertise here.
That's a good question. A lot of it is personality driven. So some people are incredibly risk averse. So we present both pros and cons. I am a transplant physician, so sometimes I'm a bit biased. So I always say, when you go to a baker, do you always get bread? But I do try and be balanced. So I show that I often will pull up. I have a PowerPoint slide where I will show the curves from the different studies, both the French and the Italian, and say, well, this is what we see now. And as you just pointed out, if you are relatively fit and you don't know what may happen in the future, so that you may not be able to get that salvage transplant. In the Italian study, for example, I think about 60% of patients who got chemotherapy instead of a transplant up front were able to get a second transplant, but 40% did not. So there are a variety of reasons. Their disease progressed, they weren't fit, there are a whole bunch of other reasons. So if you are otherwise physically fit, it's not fun to have a transplant, but it is a relatively short period of toxicity. Most people feel pretty well by 30 to 60 days following it, and they're usually by 60 to 120 days, they're usually back to their usual self, and they're able to resume a regular life. And so we do think about it. Again, we have some people who say, no, I just don't want to do it. And we will say, well, at least you need to store your stem cells. So we strongly recommend that everybody get their stem cells collected after their induction therapy, treat to best response, collect stem cells. We do recommend early transplant because of this whole idea of controlling disease for a longer period of time, because as you pointed out, there's new drugs. We had 4 new drugs in 2015, and we may have some more in 2016-17. So this is a very exciting time, at least in terms of having multiple things that we can do to help treat patients with multiple myeloma, both upfront and with relapse disease.
Mm-hmm. And let me go back to something else, because one of the other doctors mentioned the same thing you just did when we were talking about genetics, and you said some of the people didn't study the CD138 selected cells.
Right.
So one doctor mentioned so when somebody's newly diagnosed, they should always ask their doctor or even the lab if they can actually do this, if they can actually select for CD138 when they're getting their testing done, so that they're testing the right sample, right? So you have this really valuable information about your own kind of myeloma. Do you want to elaborate on that at all? Or is that something that's done just at diagnosis, at relapse? I mean, because this is something patients need to know to go ask, and they don't know that the lab is not doing something right, or doing something deeply or not.
Yeah, this is not a standard. It's become more of a standard, and we really need to make it so that everybody's doing this. In fact, I have a Twitter account, and Rafael Fonseca from Mayo tweeted about the fact that he had just seen a patient in consultation who had not had CD138 selected cytogenetic analysis, or FISH, which stands for fluorescence in situ hybridization. And it's a way of painting the chromosomes to look at chromosome abnormalities within the plasma cells themselves. And this is really very important, because if we don't get that information, it doesn't help us stratify. So a well-informed patient will be able to say, when you do my bone marrow test, are you going to send it to a lab that will do CD138 FISH, CD138 selected FISH, to look for specific chromosome abnormalities associated with multiple myeloma. And you brought up another good point, which is sometimes there's something called clonal evolution, where when the disease comes back, if it's suspected, it would be important to check, are the chromosome abnormalities still there, or are there new ones present? Because sometimes that will inform us about the best treatment. So, for example, deletion 13 is thought to be best treated, as well as 414, with a bortezomib-containing regimen, or at least a proteasome inhibitor. So this type of information is incredibly helpful with regards to telling us what may be the best way to approach this disease. Now, there's some genetic testing. Signal Genetics has something called a gene expression profile, and that right now identifies a high-risk patient population, but so far it doesn't tell us what to do about it. In other words, we know this patient has a higher risk, but we don't have a regimen that's dedicated to knocking out this risk. Hopefully we'll have better understanding as time goes on. There's a company called that does something called Foundation One. They're doing it more on leukemia and lymphoma, especially leukemia, and they're just starting to do it now in multiple myeloma, and that is a way of looking for chromosome abnormalities that are associated with higher risk features in myeloma. That's early. And there's now a new polymerase chain reaction. It's a test to look at the RNA and DNA in the cells that may identify in larger amount the multiple chromosome abnormalities associated with multiple myeloma and how these change over time. So this is all very exciting. And this is somewhat new. The PCR and more of the molecular testing, but the cytogenetic testing should be considered standard.
Mm-hmm. Well, it just seems to be if you're running studies and you have hundreds of patients enrolled, if you really had this at the beginning of those studies, you could eventually and quickly personalize treatment based on the results of these large-scale phase 3 type studies. If you had that at the beginning, it would just be so much easier.
Yeah, I mean, part of it is technology evolves, so that sometimes we see what is standard today will be outdated, a year from now. I don't think it'd be quite that fast, but the field is moving quickly, so we're trying to keep up. And so part of it is we store samples and then go back and look at them later. We incorporate new ways of understanding the genetics of the disease so that it helps us predict the best treatment. And again, with some of the new drugs we have, what we're really interested in doing is looking to see how drugs that like elotuzumab, daratumumab, ixazomib, how well do they impact on outcome for not just lower risk patients, but for all risk patients.
Mm-hmm. And my main question about this show is, as a transplant expert, you could do a typical transplant, but with all these new therapies, what's advantageous to add on the front end and what's advantageous to add on the back end? So you talked about lenalidomide maintenance, and that clearly makes a big difference. And in some patients, you mentioned that proteasome inhibitors might be used as a maintenance therapy. So as a patient who might be seen by a local oncologist, how do they go about, and we always advocate they see a myeloma specialist, but how does that doctor or how does a myeloma specialist choose the right maintenance therapy or new drug add-on in the mix with transplant? How do you come to those conclusions for each patient? Because that seems very difficult.
Good question. Well, I think we're moving away from doublets. For a transplant eligible. So if you have somebody who's young and fit and would be considered a transplant candidate, in the old days we used to do things such as lenalidomide dexamethasone or bortezomib dexamethasone as a doublet. And I think there's enough data to suggest that we really should be looking at triplets. One of the triplets was bortezomib cyclophosphamide dex. And the other was lenalidomide, bortezomib dex. And just recently at the last ASH meeting, the French studied, it was a little different. It was bortezomib thalidomide dex, and they compared it to bortezomib cyclophosphamide dex, so-called VCD versus VTD. And what they showed was the patients who got the thalidomide-containing regimen had a little bit better responses. There's no difference in PFS, but they weren't asking that question yet because it's early. They were only looking at response to induction therapy. So that made us think that perhaps the addition of the IMiD, the thalidomide, was a little bit better when combined with the proteasome inhibitor. So so at least now people then extrapolated, well, lenalidomide's a little bit better tolerated than thalidomide, so the so-called RVD regimen, or lenalidomide, bortezomib, dex, as a lot of people are using that now because it appears that using a triplet gives you better responses than using a doublet, and that you can deepen the response. So the thought is that the more you can drive the cancer down, it allows the melphalan the ability to kill off less cells. In other words, there's less cells that have to be killed off when you actually come to a stem cell transplant. So in other words, patients who achieve a CR or even a stringent CR where you can't detect it by flow or molecular testing, they seem to do better than those who have a lesser response to the induction therapy. So right now, that's sort of where people are moving towards with the sort of standard FDA-approved approaches to treatment. Now, there is a study being done in Europe looking at daratumumab with VTD, the bortezomib Valdex, and they're comparing Dara VTD versus VTD, stem cell transplant, and then a consolidation afterwards. That study's still ongoing, and that will give us some information. The only problem is it does use thalidomide, which we don't use as much now in the States. So in the Alliance, which you mentioned in the intro, we are going to be studying RVD Dara versus RVD, and Peter Voorhees is leading that trial for the Alliance, and that's a phase 2 study, so it's going to give us a signal that we hope we can translate into a phase 3 study where we can have a definitive comparison. So we think that, for example, that would be one other way of incorporating some of the newer drugs. There's interest in doing the same thing with elotuzumab as well, or substituting ixazomib for bortezomib, and that way you'd have a triple drug regimen that's all oral.
And so these are triple combinations as induction therapy, right? So you're testing,
yes,
because right now daratumumab is only for, I saw they just changed the designation, so now you can get it after you've had one therapy in a combo,
yes,
in that combo. But
yes,
that would be upfront before transplant, right? That's what you're saying?
yes. Yes, that's going to be tested.
Okay.
I'm not saying that's not standard
right.
yet, but it's currently being
tested
right
trials.
now.
Okay.
Yes, they're
that's
all
great.
clinical trials.
So,
and it is exciting because
yeah.
daratumumab, as you know, was initially approved as a single agent, but after both the EHA and the ASCO presentations combined with VD or RD, it's going to be incorporated as part of a triplet for salvage therapy for those who've had relapse after their original treatment.
Mm-hmm. And that's a quad therapy. So you're moving well beyond the doublets, right?
Yeah, and in the old days, when they tried a quad therapy, there was a study called the Evolution trial where they compared VCD, RVD, and RVD plus C. It's an RVCD. That was the quadruplet then. It was a little too toxic because it had a little too much. It had cyclophosphamide, lenalidomide, bortezomib, and dex, and the combination of probably of the len plus the cyclophosphamide was fairly tough on the marrow. So sometimes you got to get the right drugs together to get the right quadruplet, and you have to study it. So I'm not saying that the daratumumab, len, bortezomib, dex is going to be standard, but it's going to be tested to see if it will become a standard.
Mm-hmm. And elotuzumab usually works well with Revlimid, so you can combine that into that quad therapy, and that might be equally effective,
exactly.
or you'll just have to test it and see.
Exactly.
Well, it's exciting now that these drugs are available now. Now you can do all the different iterations.
Yes, we're excited about studies, and really it's just going to be a matter of having enough patients who are willing to participate in clinical trials, because that's critically important. And we are grateful that people are willing to participate in trials because it offers them access to the new agents, but it also allows us to be able to best position ourselves, and we really rely on the goodness of people's hearts to participate in trials so that 5 years from now we'll know what may be the best way to do things, and just as somebody did this 5 and 10 years ago to help us today decide what's the best approach to the treatment of both upfront and relapse disease.
Mm-hmm. Well, this program was created to encourage clinical trial participation because this is a way patients can help weigh in to help accelerate their own cure. So I would say after you have a drug that's been approved and it looks like it's working well, I would hesitate to just do a standard transplant anymore. I would want to add all these different new agents into the mix and see how deep my response could potentially get. Same thing for in a relapsed situation. I don't think personally, now knowing what I know now, I don't think I would ever do just a standard second transplant. I would look into a clinical trial and find something else that was added to standard transplant to make it even better. So.
Yes, in fact, we do know that second transplant, say the disease comes back, and some people can get a second transplant. And the British did a study where they compared it to just cyclophosphamide alone and found that second transplant was better because there really was no standard for what to do after reinduction and a second transplant versus just doing reinduction and following the patient. So we know second transplant works. That was published just recently in Lancet Hematology with Gordon Cook as the first author. But we are in the middle of trying to sort out what's going to be the best maintenance, say, approach after a transplant, both up front and then later on after if it's a second transplant. For up front, we now have a bunch of different drugs that we could potentially look at. There's some HDAC inhibitors, histone deacetylase inhibitors that are being tested or looked at. There's daratumumab, elotuzumab. There's even checkpoint inhibition with Pembro, which is another drug, pembrolizumab. So what we need to do now is sort of figure out what may be the best way to do this. So we're actually trying to develop a trial in the Alliance to look at sort of a pick the winner. We would do smaller phase 2 studies to see which one gave us the best signal and then try and look at that in a larger phase 3 study so that we can then pick which would be the best approach for maintaining disease control. There's some cellular therapies going on. There's a variety of cell products, off-the-shelf products that are being developed to maintain disease control. Some of them are natural killer cells, some are T cells. We have a vaccine trial that's through the BMT CTN, and it's a randomized trial looking at dendritic cell vaccine where the patient's own cancer cells were fused with something called a dendritic cell to create a vaccine where the patient responds to their tumor cell. You make it into like an antigen. And so this would potentially allow us as a platform for long-term disease control by allowing the patient's own immune system to get revved up to attack the cancer. And these are all sort of new studies. This one is called BMT CTN 1401. That is just opening in a variety of centers throughout the states. And these other maintenance trials that we're talking about developing, adding on to lenalidomide, whether it be lenalidomide with DARA, lenalidomide with ELO, lenalidomide with HDAC inhibitor, what will be the best platform for moving ahead so that we can potentially look at, say, a doublet for controlling disease as maintenance as opposed to a single agent. So these are all questions that we need to answer. We need to make sure they're not toxic, that the patient is able to maintain their usual quality of life without having toxicity. We don't know enough about scheduling, and then we don't know enough about how long. So these are all questions that we need to look at, and we appreciate patients who are willing to participate in these trials to be offered, as you pointed out, the opportunity to be able to have a new drug that might be able to control their disease long term.
Mm-hmm, right. And it sounds like you talked about multiple strategies. So one strategy is to add something as you're doing transplant, like this dendritic cell vaccine. Mm-hmm. And then maintenance, what you talked about earlier, is a whole separate idea. So right. And I think this study just opened just barely, like last week or something, that you were talking about, the dendritic cell vaccine. It's open like in 16 locations. So it's at a lot of different facilities. I did talk to Dr. Avigan just a little bit about that one, and it sounds like you're doing the transplant, and then several days later, you're not waiting a long time. It's not like it's maintenance therapy, but you're doing it with the transplant pretty much, and you're giving the vaccine with the transplant.
Right. Right. So what happens is the patient's own cells, cancer cells, are collected early. Then they fuse the cancer cell with the patient's own normal cells to create this vaccine, which is administered subcutaneously as a shot. I can't remember the exact period, if it's 30 or 60 days after the stem cell, but it's relatively early. And then it is given to with lenalidomide and a drug called GM-CSF to rev up the patient's immune system, so that the patient would potentially attack their own any residual cancer that still might be in their body.
Mhm. And just a point on that, a lot of the doctors have said, vaccines aren't that great if you just use them by themselves, or you have to use have a really low tumor burden. And this is a way of using stem cell transplant to knock down the tumor burden, and then use a vaccine that could extend the, effectiveness of the transplant, but also do something plus. So
yes,
I think
absolutely.
those types of studies are really exciting.
Oh, definitely, and this is one of them. We are working with one of the companies, Celgene, to develop. They have an off-the-shelf natural killer cell product where it's derived from placental cells, where they put the right cocktail of cytokines, which are molecules that help the cells grow, and they create what are called natural killer cells, which are a type of immune cell which will kill tumor cells. And they have a trial looking at it in something called acute myeloid leukemia. And they're also going to be looking at natural killer cells in, I think, about 5 or 6 centers after autotransplant for myeloma as a platform for further drug development, because these cells right now last about 2 weeks. You give a drug called interleukin-2 to help stimulate them, but eventually they sort of go away. And this is a third party. It's somebody else. Well, it's derived from a placental cell, from placental blood. So this can be grown up and expanded, then potentially used in multiple infusions to control disease long term. Or there's some new cytokines. There's a drug called interleukin-15, which might stimulate NK cells to live a lot longer. That cytokine, IL-15, is still not FDA approved. So this is a whole new area of cellular therapy to, again, help maintain response in a minimal residual state after a stem cell transplant, where it's easier to potentially control or kill off any residual disease. So absolutely, there are multiple different strategies that are being tested to see how we can control this disease long term, and as we talked about, someday eradicate it completely.
Mm-hmm. And as you go after these residual cells, I've heard some doctors, and I think there's some disagreement about this, about cancer stem cells, or at least precursor cells that might be lingering around, and that's what transplant or the other drugs may not be getting to. Do you have an opinion on that?
Oh, that's the big question.
Is that
I'm not
opening
sure.
a can of worms?
No. No, I'm pretty agnostic on this one. I don't know. There are a variety of strategies. Some people think that you're right. It is a primordial stem cell that doesn't have the features of myeloma that from which the myeloma arises. Some people feel that it's that the myeloma cell is pretty much the beginning as opposed to a stem cell. So there's data suggest both. And so we're not certain, because we do know, for example, there are certain markers that are present on some myeloma cells and not others. There's certain genetics that are associated with one myeloma and not another. And so I am taking a wait-and-see approach, because I am still not sure which is the right answer, so that we need to be looking at it, though, and studying it, so that if we think we're in a minimal residual disease state, can we be looking for other cells within the bone marrow that might be something that could be a precursor to, or the stem cell that might turn, that's lying there dormant and then all of a sudden goes malignant. as opposed to we've killed them off and we just want to make sure we keep eradicating them with our current strategies. So I don't feel strongly one way or the other. I think we just have to see what the data tells us. And because myeloma is a pretty heterogeneous disease, I think we even may see both.
Well, it makes sense that some of the cells might just not respond to the drugs that are being given. And then there might be something else happening going on that we don't know about yet.
Right. Well, it is a good example. Like I'm sorry. Just one small point. The CAR T cell study that was done. You probably had Ed Stoudemire on to talk about where they manipulated the patient's own T cells to attack CD19. And CD19 is really not expressed that much on myeloma cells. But they had one patient in whom a CD19 CAR completely eradicated the disease. And that didn't make quite a lot of sense, but it sure did work. So there's a lot of stuff that we don't understand. The same thing with there's another CAR T cell that Dr. Korchendorfer presented at the last ASH meeting, and it's against something called B-cell maturation antigen, which is also expressed by myeloma cells, but also some precursors. And for a lot of patients, it didn't work or else it just stabilized disease. But there was one patient in whom this cellular-directed therapy completely eradicated the disease. So we still don't know everything that we need to know to help us understand yet completely how we control the disease for all patients.
Is CAR T-cell research, we're helping to fund a CAR T-cell research project that's targeting CS1 and BCMA, but is the CAR T-cell stuff being used with transplant, or potentially could it be? I know right now it seems like it's using it alone.
Right now it's being used as a salvage. So in other words, if somebody is resistant usually to multiple lines of therapy, CAR T cells, either say to CS1 or it's also called SLAM-F7, that's one type of CAR. BCMA is another type of CAR. There's actually antibodies being developed to BCMA, so you may not need to develop the CARs. Because the one problem with the CAR T cell technology is you have to take the patient's own cells, you have to grow them up, with the modified chimeric antigen receptor to attack the antigen of interest. And it's fairly laborious. What would be great is if you could have an off-the-shelf, something that's sitting in the freezer that you could administer to the patient right away without having to go through growing it up. Whether or not that will ever be practical, we don't know. But these are all things that are currently in development, and there are many centers who, both in the States and in Europe, who are looking at different strategies for CAR T cells. The natural killer cell therapy I talked about earlier is relatively nonspecific. In other words, you don't have to have the patient's own cells, but it's an off-the-shelf, and it's it's somewhat nonspecific, but that may be enough to kill different types of myeloma cells in the patient. These are because myeloma sometimes mutates into different types of. They have different expression of different molecules, different genetics within the patient. Within the patient themselves. In other words, there were several clones that are abnormal, and you have to figure out a way to target all of them. So these are all questions that we have to answer by clinical trials.
Now, you talked a lot about maintenance therapy and lenalidomide, and we talked a little bit about proteasome inhibitors. When people get refractory to lenalidomide, what do you suggest to extend the life of the transplant that they just had without the Revlimid?
Yeah, good question. If somebody has progression of their disease on lenalidomide, then usually the lenalidomide is given in low dose. So if it's a slow progression, you might be able to get away with increasing the lenalidomide to treatment dose with dexamethasone. So that's one possibility. But now that we have newer drugs, there are other things you could do. If it's a relatively slow relapse, and you're seeing it progress over time, then the physician with the patient will make the decision of when to treat. here are some of your options. One is to use elotuzumab with Lendex, because the elo combined with the lenalidomide has good activity against the myeloma cells, and it doesn't have the infusional toxicity associated with daratumumab. And daratumumab now is being moved up, so now you're going to have that option. Ixazomib is another drug combined with Lendex for progression. So that's also for somebody who's not having a very aggressive progression. If you have somebody who has an aggressive progression and they're otherwise fit, carfilzomib combined with Lendex is reasonable. Some people are combining with pomalidomide as well. Pomalidomide often will allow you to rescue somebody who is Len resistant because it will salvage patients, probably via the cereblon pathway, and that pomalidomide is less affected by this type of resistance in a patient who no longer responds to lenalidomide. And then daratumumab, we might want to, now that we're going to start bringing that up more, because it used to be for more than 2 prior lines, it's going to be now something that you can bring up sooner. So right now we're in a position where we have multiple choices, and there's also panobinostat combined with with bortezomib dex. That has activity as well. So I think that we're just going to have to wait and see how this all shakes out, because we have lots of possibilities to get the patient back into response and then control the disease for a prolonged period of time.
Mm-hmm. And I guess if you've relapsed, you've become refractory to lenalidomide, you're really, in what you just said, you're pretty much in active disease control, and then you're using these different combinations.
Yeah, one thing that's interesting, too, is that the lenalidomide makes antibodies work better. So even if you have a patient who is resistant to len, if you add len not to have a direct myeloma effect, but potentiate or increase the activity of the antibodies, we're seeing that it makes elotuzumab work better. It makes daratumumab work better. Probably the same thing with pomalidomide. So we're very interested in how these small molecules, these IMiDs, enhance the activity of antibodies. Same thing with pembrolizumab. The pembro is a single agent is sort of mediocre, but when you combine it with Lendex, you get more activity.
I've heard that before, that it activates your immune system. So they use lenalidomide a lot with some of these other strategies too.
Absolutely.
So, yeah. Now, talking about mid-transplant. So we've talked about kind of pre-transplant and what's going on in clinical trials. They're adding some of these quad therapies as induction therapy. I did a show with Dr. Barty, who talked about cleaning up the stem cells before they were given back during transplant. Is there any other work that you think is significant that's being done to help make the transplant process better itself? And then I think we'll open it up to other caller questions.
Sure. That I went and read about he's using a myxoma virus, which seems to be able to target the myeloma cells that potentially might be in the stem cell graft. We most of the time treat people to best response, so they shouldn't have tumor contamination in the stem cell product. But if they did, this would be a potential modality to completely guarantee that. We think that most of the time when disease recurs, it's because there's residual disease in the patient. So as you know, there have been some strategies trying to use viral-mediated therapy. There was a measles virus study from the Mayo Group where you actually target the measles receptor. It's kind of cool, which is expressed on myeloma cells, so that you actually get the measles virus in and kill the plasma cell. These are all sort of not quite ready for prime time, but these are very interesting avenues of research. I think the most important thing is still control of disease in the patient, that we can probably get a pretty clean stem cell product if we can drive the disease into a way and have the patient now have a stringent, complete response, so that we'll collect stem cells that will be relatively clean. I think it would help guarantee a clean stem cell product, but I think the big problem we have to face is disease that's still in the patient that we need to figure out a way. The high-dose melphalan knocks it down further, but what can we do to eradicate those clones, whether or not they're hiding out as stem cell precursors, or they're laying dormant as plasma cells and are not as affected by the medications that we currently use. Or maybe they will be by such things as the antibodies, which will allow the immune system to target these cancer cells and get rid of them.
Mm-hmm. And then when you reviewed all the different international studies and you saw one of the arms comparing single versus tandem transplant, does that provide benefit?
Yeah, that's still not quite a clear question because all the earlier, the MN02 study does look at single versus tandem, but they didn't report on that. They suggested that maybe if you got two, you did a little bit better, but it wasn't. That wasn't the primary point of his presentation. So we'll have to wait and see from that study. As I mentioned earlier, BMT-CTN0702, that will give us some pretty good information in the modern era of the utility of two transplants. It's tough to get through two. It's hard to get through one, but some people are able to do that. And the issue becomes, do you need to get two back to back, or can you save it for later on? And those are questions we don't have the final answers to. We do know that for patients who don't, in Europe at least, the standard is if you don't have a good response, or if you're not at least a very good partial response, at least a 90% reduction with one transplant, you should get a second. And so I think that, again, that's done more often in Europe. Some places in the States do that as well. So I think the data is not completely in, especially now that we have these new drugs which drive people into better responses. We may not necessarily need to do two transplants, but it's still an open question.
Mm-hmm. Well, that's great. Now, do you have any other comments about add-on strategies that could be adopted? We've gone over a lot. And the time goes so quickly, and there's so much to talk about. But I want to leave it open for you to make some final kind of assessments before I open it up for caller questions.
No, I think the most important thing we did touch on is we are so happy that people participate in clinical trials. And I'm glad that you're sponsoring one, because I think this is what will allow us to advance the field and come up with the best strategy for someday completely eradicating this disease.
Well, I completely agree. And as a patient, I want to come to conclusions as fast as possible and help you, people like you, and the researchers who are doing this incredible work come to their conclusions faster, because it's really in our self-interest to do that. So it's great, and the work that you're doing is truly great and incredible.
No, I appreciate the opportunity. Thank you.
Well, we'd like to open it up for caller questions. So call 347-637-2631 and press 1 on your keypad if you have a question. So we'll start with our first caller question at 558-8163. Go ahead with your question.
Yeah, hi, Dr. McCarthy. Thank you for being on the show. My question is about when to use a second transplant or not to. How long should the first one have worked in order to consider a second? And I know some doctors say, why do a second if the first didn't work well? It's very long. So maybe you could help me out understand that a little better.
Sure. Yeah, a lot of it has to do with length of time. So in other words, as a rough rule of thumb, if the disease progresses requiring therapy, especially after 18 months, and even longer, 2 years, 3 years, 4 years, a second transplant probably will be of some benefit. If the progression is early, like within a year in particular, it's less likely to be a benefit to do a second transplant because the disease came back fairly quickly after the high-dose melphalan. So everybody has a slightly different place where they cut it. Some people do it at 12 months, some at 18 months, some at 2 years. So I think that's what people are thinking of, that if it took a long time for the disease to come back, thus the second transplant may be a benefit because, again, there was a good response to the first transplant.
Okay, thank you.
Sure.
Okay, great. Thanks for your question. Okay, our second caller, 204-6956. Go ahead with your question.
Hi, can you hear me?
Yep.
Yes. We can hear you.
Oh, okay. I'm sorry. I have a question about your thoughts on allo transplant. Where does that fit in all of this? And there are a few clinical trials. I know that there's one at Johns Hopkins, and I think there were a few that were opened at MD Anderson that seem to overcome the mortality rate from graft versus host disease. So thoughts on that?
Sure. There was a trial that had been open. It's going to reopen again called BMT-CTN 1302. And that is a reduced intensity allo transplant. And there's a back-end randomization to ixazomib versus placebo to see whether or not the addition of ixazomib could help control the disease in an allo setting. As you pointed out, the major toxicity that we face in an allo transplant is graft versus host disease. And it can be, people can die from it, so that we are trying to come up with the best strategy for a very high-risk patient population. So if we do offer allo transplant, it's usually in patients who have diseases such as, say, plasma cell leukemia or very high-risk multiple myeloma, or occasionally. So, for example, I have a patient, he's 32 years old. It took 3 different regimens to finally have a semblance of control over his disease. So we're going to do, for example, unfortunately 1302 is closed right now. We would have offered him that trial. But we're going to offer him an allo transplant just because we are so concerned that his disease won't respond to the auto transplant. So we don't do a lot of them. The vast majority of patients at our center undergo an autologous transplant because they often do so well with it. But for patients that we've identified with our team as being very ultra high risk, we will offer them an allo transplant. But as you pointed out, there are nobody has the right way of doing it. So there are a variety of different clinical trials that are being developed to see what may be the best approach to controlling the disease and minimizing the toxicity associated with allo transplant.
Okay. I have a follow-up question.
Sure.
If a patient elects to do an allo transplant, I forgive my ignorance on this topic, but how much thicker to control the GVH, how much thicker or more awful would a patient feel compared to their transplant?
Well, we don't have, unfortunately, I have this discussion a lot with patients because sometimes we cannot predict who's going to get bad GVHD, for example, and who doesn't, where the donor cells attack not just the cancer, but they also attack normal tissue. And when they attack normal tissue, you can get very sick from that. So we don't yet have a way of predicting who is going to get bad GVHD and who is not. There are some strategies now that may suggest early onset of GVHD so we can intervene early, but they're still not ready for prime time or universal acceptance. So we don't know yet which is the best approach. But we do know that we are trying to develop what are called reduced intensity transplants so that we get the patient to as best response as possible, take them to the allo transplant where there's as little disease around as possible, because if there's too much myeloma around, it makes it very difficult for this graft versus myeloma effect or graft versus tumor effect. So you can get fairly sick from this, but then we have some patients who we call them, they sail through it because there's minimal toxicity. So until we better understand all the predictive factors, we can't say with 100% to a patient, oh, you're going to do just fine or you're going to have a fair amount of toxicity. Just yet. We're getting close. A lot of it depends on the age of the patient, how much disease they have, what kind of donor they have. But we don't have it nailed completely where we can say to a patient, we can really guarantee that you're not going to have that much toxicity yet.
Okay. All right. Well, thank you. Thank you for taking my question.
Sure.
Oh, thanks for your question. Well, Dr. McCarthy, thank you so much for joining us today. We're just thrilled that you're working on all these different iterations to make transplant better and to extend outcomes and potentially cure patients. We're very, very grateful for your daily work and dedication for us. So thank you so much for all you do.
I think it's so wonderful that you have this radio program because it's part of getting the word out to patients so that they can best understand what their treatment options are, and be an informed patient so that they can know the best strategy for trying to control and someday eliminate the multiple myeloma.
Yeah, I agree. And if we ask better questions, we're going to get better care. Because it's better to tap you when you come into when we come into our appointment, and ask those important questions rather than not when we have your
Absolutely
time. So, yeah, we're so thankful for you. So, thank you so much for joining us, and we thank you for listening to another episode of Myeloma Crowd Radio. Join us for future shows to learn more about the latest myeloma research and what it means for you.
Hello, it is Ryan, and I was on a flight the other day playing one of my favorite social spin slot games on ChumbaCasino.com. I looked over at the person sitting next to me, and you know what they were doing? They were also playing Chumba Casino. Coincidence? I think not. Everybody's loving having fun with it. Chumba Casino is home to hundreds of casino-style games that you can play for free anytime, anywhere, even at 30,000 feet. So sign up now at ChumbaCasino.com to claim your free welcome bonus. That's ChumbaCasino.com and live the Chumba life.
No purchase necessary. VGW. Void where prohibited by law. See terms and conditions. 18+.